We spoke a lot about the acute treatment, and we switch gears now. First, before I go into that, our disclosures, lots of these data were gained through funding from the Japanese government, from the German government, from LNI, mainly from our State Department, but that's it. Not company funding, but I'm more recently, a consultant for Cyberdyne. Well, our hospital is one of 9 hospitals within the LNI system. We call it BG system, where all work-related injuries are going to. So these are central hospitals distributed over Germany, and injuries and complications after injuries are treated in these specialty centers. This goes back to the 19th century when Bismarck actually started a new insurance system for the injured people at work. And at that time, the idea came up that the industry should pay for the injuries which happen during the work. Number one. Number two, it was requested that we need specialty centers which just take care of work-related injuries and which should put all disciplines related to these injuries into one department or in one hospital. And that is the reason why already our radiology department started in Bochum in 1896, and you may remember that X-ray was developed and founded in 1895. Also at that time, the philosophy that rehabilitation should be closely connected to the acute treatment was standard of care in our institutions. So 1892, this was a picture of the rehab department. And we are glad that we are now going into new directions and we are not at the same level. We are now evaluating different types of exoskeletons, and that is the subject of my talk. Well, what is an exoskeleton? This is an external device which we can wear. It was originally more or less developed for military and for industry use, but there are applications in the medical field. And there are 3 systems mainly under discussion right now for spinal cord injury patients. This is the Arbor medical system, the exosystem, first of all, an American development, which enables the carrier to kind of walk, but that is something where the person is being walked. So the carrier presses a button, or a therapist presses a start button, and then the machine walks the person. And that enables people, like incomplete spinal cord injury patients, to actually stand up and do some steps. And very similar is the philosophy of this Rewalk system, where they have like a board on the arm, a control board, and then you can start certain programs, and they allow the patient to actually walk, stand up, and so on. I would call these passive systems. Well, the carrier is still under control of the system, but not direct control, because the machine is running a program. And that differs from a Japanese developed exoskeletal system, which is connected to the neural system. Well, originally these robots were developed for geriatric patients or people, because in Japan the population is much older than here in the United States or in Europe. So they need additional devices to keep the elderly people outside of institutions, and they want to keep them mainly in their normal environment. So therefore you see here certain applications: single leg, upper extremity, lower extremity, heavy work things, and here in geriatric institutions. Well, how does that work? If we want to do a motion, we initiate voluntarily, most of the time, that movement through a signal which comes from the brain into the spinal cord. And if we have a spinal cord injured person, an incomplete one, or a person where some signals are still going through into the extremities, then we have a weaker signal going to the peripheral nerve, and that initiates some muscle function and tone. But this may not be enough that the person actually can function, and that may be the reason why a person then is wheelchair bound and cannot be mobilizing. However, this system is taking percutaneously that signal with a sensor, and the sensor triggers then a motor at the knee or at the hip, and that supports the muscle function. As long as that signal is coming from the brain through the spinal cord to the muscle into the periphery, that motion is supported, and thereby you have a direct control of the machine, a voluntary control, and therefore I would call that different than the other exoskeletons. I would call that an active system. This results, of course, in a feedback, and the person can then stop that motion or initiate further developments. So you have a closed feedback system, and in our understanding, that is necessary to actually allow nerve regeneration or neural system reorganization, and I will show you some of these results. It also enables the carrier to actually allow to train muscle groups which are beforehand cannot be trained because certain muscle groups are out of order and cannot go. And I want to show you how this works. Well, there are several medical indications where this can be probably used. Since we are a trauma center, we concentrated on spinal cord injury patients, and I want to share that with you. But beforehand, I want to give you a couple of numbers about the Spinal Cord Injury Society in Germany and Middle Europe. We have around 2,000 newly SCI patients each year, and these data are collected in the EMSKI database, which has been mentioned before. And from these data, we know that, and it was alluded to during the previous two lectures as well, we know that there is some recovery during the first year, but after that 1 year, this is the gain and the recovery is kind of leveling out, and that is where we stand. And these are some of the graphs out of the EMSKI database. So you see always after about 1 year, the function, the SCIM, the Asia motor score, and of course others are leveling out, and that's where we stand. So we know that complete spinal cord injured patients rarely can walk, and if so, only with cumbersome orthoses, and non-long-lasting results. Age may also have an influence. In reality, the rehabilitation in these patients is very cumbersome and problematic. You know that there are all these different options. There are body weight support systems with and without, manual support and guidance with electric stimulation and so on. But it seems that there is no significant increase in walking speed. There is significant increase in walking speed when you do this rehabilitation. However, there are no significant differences between the different types of rehabilitation. So it seems to be important that something is done, but what it is may not make a difference. Because that is really person and time consuming. More and more efforts are put into the development of robotic support. And during the last decade, locomotor training became an option. The Locomat is one of the major accepted machines which is used. So the patients are in a body weight support system. They are bound and connected to the Locomat, which actually moves the legs and trains the persons. But also the multicenter studies so far show that the walking speed is increasing in these patients, but there is no significant change in the requirements of walking aids, orthosis, or external physical assistance. When we talk about rehabilitation in SCI, we also have to recognize that there is a difference in neurologic outcome and functional outcome. The functional outcome is typically becoming much better than the neurologic outcome. However, incomplete or high-grade incomplete SCI patients, we typically accept that we train them only or rehab them only to a wheelchair status. And if Transfer capabilities are established. Rehabilitation is often largely considered successfully completed, and after about 1 year, there is not really a functional change expected in these patients. And that is at least the understanding where we start and where we started with our studies using that robot system. So we wanted to check and see how these exoskeletal trainings can benefit in our patients. Since during the first year, there may be, during the natural history of the diseases, an improvement in these patients anyway, we decided at that time that we only include patients who are out of their injury more than 1 year. All of these patients who are included here were LNI patients, which means that they went through a 1 year, almost 1 year constant rehabilitation program. Since the LNI is one of the most intense post-operative treatment rehabilitation programs in Germany, this is what we can gain in these patients, but then that's about it. So here you see the robot for the lower extremities, and I will explain the model later here. There are sensors put on the skin for the hip and knee extensors and flexors. The patients are placed in the body weight support system on a treadmill. The machine can very easily be adjusted to the height of the and size of the people. And there is a little control unit in the back where you can actually measure the EMGs from all the muscle groups which I presented to you and showed to you before. And then if for each muscle group individually, the support of the motor of the machine can be adjusted. So with this system, you can actually train the different muscle groups independently, left and right, and each muscle group itself. And then you start the training. This was one of our first patients. So he was an LNI patient, more than 1 year out of training. He had an Asia A, but zones of partial preservation to L3. So he had some function, and you can see him there after 1 year. And if you look at him, you can understand that he is wheelchair bound, although he has some function in his lower extremities. He needs a person to assist. He needs to walk on the stand, on the frame, and that's it. He's 35 years. He has an own running architecture bureau, and that's a problem for such a person. So here you see him at the beginning with this robot, and you see that he is really doing controlled steps. Remember, he has to think about every step that he does. And that looks very slow, but every motion he is doing there, he is doing voluntarily. Here, this is after around 4 weeks. When we started the study, we said we want to see what the system is really doing and helping. So all of the patients had to do training every day, 5 times a week, and that for 3 months. And we recorded, of course, on the treadmill, the walking speed, the distance, and so on. But we also wanted to know and understand whether their function without the help of the robot becomes better. And therefore, we also checked the 10-meter walk test, 6-minute walk test, time up and go test without wearing the robot. And we did these tests before that training series and after the training series for 3 months. So that is a different concept than you would normally have with the regular passive exoskeletons, and that has to be understood. That is a training instrument and nothing to support. Now look, she is increasing the speed of the treadmill, and you see that the step size is changing. So the robot is not running a fixed program, but the person can actually adjust everything that he, in this case, does, and you can do individual training. Well, these are a couple of numbers from this patient. So the 10-meter walk test without wearing the robot suit were at the beginning 72 seconds, 31 steps, walking frame with personal assistance. When wearing the robot suit, he could walk 200, in this case, 200 meters, and the speed and everything is written down. But after a couple of months, and remember, he is 1 year out of his injury, went through a whole complete program, these numbers increased dramatically. But these were numbers, and I think it's better to understand what's happening here if you look at these films. So you see the video when he started, you see him at 3 months, and actually after 5 months, he was able to walk in this walker. And that was a completely unexpected result, which we had in these patients. Well, he continued that training. First of all, here I show you the difference in walking with the robot. And now you recognize that he is actually going very easy. So lots of that walking is becoming more and more automatic. He continued the training, and he started on crutches. This was the status at the end. He can walk now on crutches, 1 stairs, 1 level, and that's it. And that is something which shows us that even after a year, you can get dramatic changes in the function of these patients. In a consecutive series of such patients, we always saw these functional improvements in the chronic SCI patients. However, we saw some other results, astonishing results, and I want to share these with you as well. So this is a 54-year-old lady, incomplete Asia C. She increased in her function as well, but after the 3 months training where these patients trained like every day, some of the patients continued training in the same frequency. Others went on an interval training for once a week, and that's what she did. However, after around 9 months, she came back and said, I do not need to self-catheterize anymore. And we sent her to urology, and indeed, she didn't have any remnant urine anymore. We do not understand, and we saw that in a few patients. We don't understand what's really going on. There may be a very easy reason that just the musculature around the trunk and the pelvis is becoming better because you train these patients overall. We do not also understand what's happening with recovery in the autonomous nervous system. We know that bowel movements are related to activity in these patients, and that's something else which we see in these patients, that they are getting much better. Another patient, his injury was 96, and about 6 months before this video was taken, he fell out of his wheelchair and he had a pertrochanteric fracture, which threw him even further back, and he was severely impaired there and was not really mobile. So he is also Asia A, zones of partial preservation up to L3. He gained very quickly his motion back, and you can see him here. It's a little dark. Of course, that's not a normal gait, but he is independent, and he can perform daily activities much easier. And you see him here again, the same phenomenon, that these patients are getting much better in their walking. This was his sensory status when he started, and in short, after 6 to 7 months, he had a skipped additional dermatome at S2 on one side and later on the other side as well. We see this in quite a few patients, that there are additional segments coming up. Typically, it's the adjacent segment to the injury, but there are patients where we see these skipped additional areas, and that's of course very important because it helps for decubital ulcer prevention. In regard to cortical reorganization after spinal trauma, we all know that there is a reorganization. And this reorganization correlates with neuropathic pain in these patients. So, and we also know that the training and rehab has influence on the reorganization as well, and therefore we did functional MRI in these patients. And this, because of time reasons, I don't want to go into this indirect measure, but we saw that after 6 weeks already, and definitely after 12 weeks, there was a tremendous change in the pictures which we saw in the functional MRI. We correlated that also with neurophysiology examinations, and we could definitely show there, and that's published, that the health training normalizes cortical excitability in the primary somatosensory cortex in the chronic spinal cord injury patients. Now, if that is true, then we would expect that there may be some changes in the neuropathic pain. And also there we have a few patients, like this one, who originally just came for functional improvement and training, but he described that after the training, the shooting pain sensations which he had in the leg are decreasing. And he finally could get off his opioid treatment altogether, and I will allude to that again later. So in the pilot study at the beginning, which included 8 consecutive patients, and you see here time since trauma, 13 years, most of them 1 year, 16 years, and so on, we had significant changes in the walking distance when using the robot, but also in the functional results, and I just show here the 10-meter walk test, and astonishingly in the low extremity motor score. Also the 6-minute walking test, which could only be done at the beginning by 3 patients, at the end of this training, 8 of them, all of them could actually perform that. Because of these results, we were able to build up a specialty training center for this robotic training, which you can see here, and we have now 50 patients completed with a full term of 3 months training, chronic spinal cord injury patients, and the results were even statistically much better. You see here the walking distance on the treadmill, the walking speed, and walking time on the treadmill. It didn't increase here anymore because we limited to that half an hour of training. And these are the results, functional testing without wearing the robot suit. And you see here the 10-meter walk test, the steps needed for the 10-meter walk test, 6-minute walk test, and time up and go test. And we see small changes, but definitely significant changes in the scores for low extremity motor score and for sensory. So the question was now, are these results lasting? Or is this like something which is just happening during the 3 months and then the status is decreasing again? So our pilot study patients, these 8, we divided into 2 groups. One group was, and these are small groups, of course, one group continued like 1 training per week, and the others were in a high frequency 3 to 5 training sessions per week for 1 year. And we could see that the results, and it didn't depend on the type of testing, functional results with and without the robot, they stayed on the same level. Also, there was no difference between the 2 groups. Of course, very small groups, but it's not a big step. And I would explain that, or we understand that as soon as the patients are on a different level of their daily activities, if they are out of their wheelchair and can walk, they will train themselves anyway and will continue being on that level. Neuropathic pain. Well, we know that there are treatment refractory pain in a variable number of patients, and the literature is there inconsistent. But there are these patients, and in the pilot study, there were 2 patients who definitely increased in their pain scale, which you can see here. We wanted to quantify or objectively see whether that is true, that they are off their medication, and some of the medication have influence on the liver enzymes. So we checked the liver enzymes in these patients, as you can see here in this graph, and they decreased, so that was an indirect proof to us that they are really off their medication. If we have these good results in chronic spinal cord injury patients, then of course it makes sense to go directly into the acute spinal cord injury patients. However, there is no control. This is very difficult to do and to analyze. Therefore, I just want to show you a few patients, how they behaved during that training. So you see here a 35-year-old gentleman, incomplete, below T10. He started 8 weeks after his injury, and after 8 weeks of training, you see him there, and on the treadmill. After 4.5 months, you see him walking on crutches, and the treadmill was put in the position so that he walks upstairs, so we can do all these different types of testings. And then he got kind of lost to follow-up. You have to understand, in the LNI system, if a patient is impaired, they get a pension. So if they become better, their pension, their payment is going down. So he didn't show up anymore, but after 1.5 years, we had to evaluate him for the insurance again, and he was doing quite well. Another lady, this was number 1. This is number 2, included of the acute patients, spinal cavernoma. Of course, they will do good, or lots of them, but we were astonished how quickly these patients were kind of getting better. And you see her here after 3 months of training. These are the initial results of 25 consecutive acute patients, and you see again highly significant changes in the walking distance on the treadmill, walking speed, walking time, and also in the functional results. So it's supporting that what we have seen in the chronic spinal cord injury patients, and we are currently trying to match these patients with the similar patients from the EMSKI database so that we have there a better comparison. So indications for this type of treatment are functional incomplete paralysis below C5-6. You need at least some muscle strength according to Yanda 1-2. Sensomotoric complete conus cauda lesions with zones of partial preservation for hip and knee flexion and extension can be treated, and there are contraindications typically to the size of the patients because they won't fit in the robot, contractures, severe osteoporosis, decubital ulcer, and so on. So it has to be understood that this system has a different aim than the typical exoskeletal system. We do not want to use it as an auxiliary tool, like a high-tech orthosis. It's a training tool, and that differs. What is next? That was the question, Jens, you rose. This is training of the upper extremity, and you nicely can see first that there were the sensors on the skin, and it was moving actually the robot without wearing it. And there we can actually, in incomplete tetraplegic patients, start to mobilize them. Also, what is next? The brain-machine interface for the complete patients, and the research group is working in these things. We currently use the HAL robot suit for balance training, for independent gait training without eye control. You see that the patient is distracted there with the ball. We can train with that system downhill, uphill, walking, backward, forward, and we also can use that machine for independent gait with some support without of the treadmill, so you can train them to walk over obstacles and other things. And the important thing is to understand that we want to give the patients back the independency. We want to get them out of the wheelchair even after a year of rehabilitation, and that is a patient 7 years post-trauma. So you see how cumbersome it is to mobilize him, and you see him here doing the time up and go test 3 months later. So 7 years after his injury. And that makes, in our eyes, a big difference. Because of time, I want to give you some final ideas about the mechanism behind that. The voluntary drive, which I described, together with the normalized motion assistance, which the robot gives the patients, allows muscle training, muscle hypertrophy. By theory and what we know from the science, there should be peripheral neuronal sprouting, but we cannot prove that in the patient. Definitely, it's a foundation for proprioceptive feedback loop. The neural activity, which is still there, plus the repeated executions of specific tasks, promote learning. We know that. It leads also to reinstatement and restructuring of appropriate proprioceptive feedback. And by looking more on the neuronal mechanism, we know from several other studies that locomotor training restores some spinal reflex circuits. It also promotes the presynaptic inhibition, and that helps us for better coordination of the antagonistic and agonistic muscles, especially in the impaired segments. So that plays a role, and it seems that this training is optimizing that whole process. But from our studies, we also know that the Hall walking improvements are related to renewed cortical representations, for sure. And that has been supported by another study in Japan by Matsumura. It also is likely related to recruitment and more effective use of the remaining efferent pathways and cortical spinal tracts. And with that, I want to thank you very much.